becoming involved. But sometimes we're actually stuck at that point because a lot of the community programs are full. So I think that this is a really important discussion and conversation to be having. I think that we really do need to scale up efforts and availability of safer supply. And with that said, I'm really happy and excited to be here. My role is as moderator for this discussion. I think that pharmacists have a very important integral part really in providing safer supply, and yet sometimes don't always get a big focus when discussing safer supply. So this is a really welcome opportunity, I think, to discuss and share insights and perspectives from some of these pharmacists who are directly involved in providing safer supply. So with that, I'm going to ask the panelists to each introduce themselves. Jodi, would you like to go first?
Hi, my name is Jodi Cunningham, and I'm a pharmacist in Vernon, BC. We have a very sort of significant population of patients that we are providing safe supply for currently. And so over the last 3 years, we've seen a significant shift, I guess, in our community and some of the willingness of prescribers and other service providers to come on board with this, but there's a lot of challenges we see too. So I'm excited to be here to talk about that with you.
Great. How about Laura? Would you like to go next?
Hi, everyone. My name is Laura Miller. I'm a pharmacist working in Nova Scotia. I wear a couple of different hats. One of them is as the provincial Bloom Program Coordinator, which is a program that supports community pharmacies across the province to help engage in care and support for patients with mental health and substance use disorders. So I am the clinical and operational support for that, as well as I teach at Dalhousie College of Pharmacy. I teach many things, but one of the main things that I teach is a new substance use disorder course. So while I'm not directly involved in providing safe supply in my current roles, I am directly involved in supporting pharmacies and in a lot of my policy work in creating policies around safe supply in our province. So like Jodi said, there's lots of challenges. There's lots of new, there's lots of practitioners that are willing to do it, but we just need to sort of find some workarounds there. So I'm excited to be part of this conversation to see if we can help shift the way of thinking. Thanks for having me.
Great, thank you, Laura. What about Lynn?
Hi, everybody. I'm Lynn Pollock. I'm a pharmacist. I work with the Ministry of Health in BC, as well as I work with the Overdose Emergency Response Center in the Ministry of Mental Health and Addictions. And my role is trying to get safer supply out and available to the province in a fulsome way, which has been very challenging, continues to be challenging. There are all kinds of ideas, but there are a ton of barriers out there that you would never have imagined when I started this sort of journey a few years back. But I think specifically one of the biggest barriers is that a lot of, we have a number of issues around trying to find enough prescribers for the, particularly for the more forward thinking group in terms, because we have a lot of fentanyl products on our prescribed safer supply list. And of course, the doses are extremely high and the prescribers are very concerned about being part of that process. So we're looking at expanding prescriptions and prescribing authority. We now have nurses doing some prescribing. We have obviously nurse practitioners who are picking this up, but there's a lot of discussion about moving some of that potential prescribing to pharmacists in certain circumstances, under certain conditions. We're trying to move, right now a lot of our safer supply programs are focused in clinics, which isn't the intent because clinics have a very limited capacity. The intent is to get it into the community, and that one of the best conduits that we have is through pharmacy. So there's a lot of work going on behind to try and increase the impact that pharmacists will have the whole issue of safer supply. Anyway, there's a ton of stuff to talk about. I'm sure everyone's got things. It's a pretty exciting topic in a lot of ways.
That's great. Thank you, Lynn. Danny, would you like to go next?
Hello, my name is Danny. I'm a community pharmacist in Guelph, in a small city. Our safer supply program started maybe about a year or so ago. I just call myself outreach pharmacist because I actually do direct care. I actually see the patient on a daily basis. So it's a bit different than from sitting behind. So my objective, besides just the distribution piece and making sure they got the medication, is to understanding the relationships and the barriers, and also make connection relationship with other organizations that actually support safer supply at the same time. In Guelph, we basically kind of have two pharmacies doing the majority of safe supply. We have a brick and mortar store downtown, which for people to come in. My piece is mostly for people that are either a mobility issue or mental health issue that's harder for them to go to a pharmacy on a daily basis. I actually go and see them on a daily basis. That's the piece I'm working on, and try to understand more in the barrier through time.
Thank you, Danny. Mark?
Hello, everyone. My name is Mark Bryans. I'm a pharmacist and the owner of Respect Rx Pharmacies. We're a group of inner city focused pharmacies, kind of dedicated to complex mental health and substance misuse. Of course, it doesn't really stay there. It's still full pharmacy service. We are community based. I also sit on a couple overdose task force, one with the drug advisory group at Eastern Ontario Health Unit and one at Ottawa Public Health. My whole role at the company is community outreach. Within my role with Safer Supply is we are part of the Ottawa Safer Supply bid that actually is funded through SUAP as well. And we have about 400 clients who are on Safer Supply in and around our pharmacies. So we do a lot of outreach in many different ways, I guess, to support clients. And what you learn quickly in Safer Supply is that you really need a more holistic care model in and around someone's safer supply, because really it's, though we're healthcare providers, it's really not treatment, right? It's supposed to be a precursor treatment maybe. So when those conversations are had, we're preparing people for hopefully a better future. And then of course, a lot of the barriers and social issues that present themselves during then have to be combated by community pharmacy. So I'm thrilled to be here. Thank you.
Thank you, Mark. And what about Ash?
Hello, everyone. My name is Ashraf Yacoub. I'm a pharmacist, community pharmacist at the Ottawa Medical Pharmacy here in Ottawa downtown. I've been with the Safe Supply program since it started at the 55 ECLs for the past 2 years, and great collaboration with them and seeing more than 50 to 60 clients a day. I believe that a Safe Supply program actually saves lots of lives. It's actually helped lots of people. That's why I'm here, and thank you so much for having me.
Okay, great. Thank you so much, Ash. So we have a lot to discuss today, so I think why don't we just jump right in. To begin, can we just cover the basics? What exactly is Safer Supply, and what would you say is the role of the pharmacist in doing or providing Safer Supply? And just as a reminder, if the panelists wouldn't mind trying to either raise their hand or use the raise hand function, just to ensure that everybody sort of gets a chance to speak. Lynn, go ahead.
I might as well start it off. I think the part of the question I found most interesting was what is Safer Supply? And I think that in itself is worth discussing, because in my head and in, I think, the head of the people that I am working with, Safer Supply is basically that. It is trying to provide the closest thing that you possibly can to whatever the person is using now in the street supply, provide them with something that is the closest alternative that we can come up with, so that they are willing and protected by using the safer supply. Not, in my mind, safer supply is not just providing an alternative that isn't suitable. Say, for instance, we started off with doing hydromorphone tablets. We found out that a lot of people, they took them, but they didn't really use them. They diverted them, or they did whatever they did with them because hydromorphone wasn't what they actually needed, which is why we're now at the fentanyl stage. So I learned very quickly that safer supply isn't just providing someone with something that is sort of in the same category that is safer, in other words, not tainted, but it actually is very, that hopefully will be more successful if we go directly to or provide something that is very low barrier. It's really switching one thing for another. It's here, you take that, I'll take this. Here's the safer version of what you're taking. And I think that that's what we're trying to do. And it's difficult to actually, it's not that simple, but in my mind, safer supply is as close as you can possibly come to whatever it is that people are using, because that's what's going to keep them on the supply and not diverting it or dropping off the use of it. But also, trying to be as accommodating and as simple and as straightforward in that access as possible without a lot of medical barriers associated with it.
Yeah, and I think that important piece about low barrier is a really good point to remember. Jodi, you have your hand up.
Hi, yeah, I wanted to say that one of the first things that I encountered with this when we started Safer Supply during kind of the height of the COVID pandemic and a lot of our patients needing to isolate, to get my own head around it. There's an article on the Katie website, Safe Supply, what is it and what is happening in Canada? And I found that was really helpful to help frame sort of my perspective around it. And I shared that with some of the physicians who were initially reluctant. And it really highlights that safer supply, although of course the biggest risk is the toxic drug supply, but it's safer in all the other ways that it reduces other harms associated with drug seeking and some of the survival things that people have to do in desperation. So it really, like I said, it's beyond just the drug aspect of it, the chemical. It really encourages safety in other ways. So I found that was helpful to share some information that kind of highlighted that. And in my practice, during the initial period where people were isolating for 2 weeks, I do outreach as well and deliver daily to people. And we had people that were isolating in a hotel setting where I would go every day. And to see the difference in those patients after 2 weeks of being on safer supply versus toxic street drugs was startling. And that for me really solidified in my mind that this is what needs to happen. This is what we need to do, because you could really see the differences.
Thank you. Laura, do you have your hand up as well?
Yeah, I think Lynn and Jodi have really highlighted what safer supply is, but I just wanted to add that in the world of harm reduction, we always use the phrase, meet people where they are, meet them where they are. And the medical model tends to say, well, you're there, but you really shouldn't be there. You should be here. You should be on OAT. You should be on IOT. You should be, so we're going to actually put you there. And that's really not meeting people where they are. Whereas safer supply says, hey, I see you. Your life has value. You're using substances. That doesn't mean that your life doesn't have value. Let's get you on something that is safer, that you can still use as you are using your substances. And then if and when you become ready to engage with treatment or et cetera, we can move forward. It's the beginning of that relationship and really the heart of meeting somebody where they are, and valuing that life no matter if they're using substances or not. So I just wanted to add that piece.
Yeah, I totally agree. I think that's a really good point about often we think we're meeting people where they're at, but maybe that's not exactly what we're doing. I think safer supply is definitely moving forward in the right direction. Danny?
I just want to add part of the advantage of safer supply also is helping decrease crime in many ways, because now the person don't always have to look for the next hit. And sometimes that if they're really stable and safer supply, because we see them every day, it also cut down ER visits and other stuff that goes on. And housing is an important piece to go along with safe supply. And hopefully once someone can stay on safer supply for long enough that we can house them better, often when unstable, we can't house them at all. So I thought I'd just add that.
Yeah, very, very good point. Lynn, go ahead.
Well, I just wanted to follow up on that comment around potentially reduction in crime, or at least decreasing the financial burden on families or whatever it is. We're actually having that debate right now in BC around, there are some people who don't believe that safer supply, when we get into some of the other, like the fentanyl capsule models and that kind of thing, that they should be free, that they should, and covered, they should be on a payment basis because it diverts or it decreases diversion and will have some impact on organized crime on the street. And others that want these products to be under a coverage model through the government. And it's actually an interesting conversation that's, I think, making everybody sort of sit back and try and figure out what is the best way forward. Because the downside of charging, if you're charging in a street value cost for the replacement, is that you don't decrease crime because people still have to come up with the same amount of money, and they take the money that they should use for their families to, support their drug use. So it's a difficult question, and it's raised its head in BC for sure, and it's something that we're looking at and considering right now.
Laura, go ahead.
I just add that safe supply also allows for the space to take a housing first approach, because it gives somebody the capacity to take the brain power that they use every day to source and access their drugs and, hunt them down and, get the money and everything. That brain power is massive. And to take that brain power away and that stress away from them really gives us the opportunity to say, let's get you housed. And housing first should be, in my opinion, the way forward for everybody, whether or not they have access to safe supply. But it's another thing that we can use to really give the person the capacity and dignity to think for themselves and advocate for themselves in a housing first model. So yeah, I just wanted to add that.
Yeah, 100% agree with you. I think it allows people to function, right? As everyone else does who's housed, or everyone else does who has a job or whatever, and doesn't have to worry about those basic necessities of life. I wonder if we want to move forward with talking about the role of the pharmacist then in providing safer supply in any way. How do we see our roles individually and what it is that you do? Anybody want to jump in? Mark, go ahead.
The important role of a pharmacist in safer supply is completely opposite to everything we've ever learned in pharmacy, and probably bothers the soul of most pharmacists, is to take your treatment hat off. Okay, take it off. Take off what you think is correct. Take off what you think is right. And we really have to do a better job, because we're seeing a ton of stigma in pharmacies, and I'm hearing stories throughout our country, though there's pockets of great pharmacists, guys, everywhere, don't get me wrong. But we have to take off our treatment hat and really open our mind up to stop defining success for our clients and allowing them to define success for themselves. When you do that, it is liberating for yourself. You remove your own personal judgment and guilt, and you actually then realize that a person gets better tomorrow based on their own definition of what is better. And if you have that perspective with safer supply, who cares what you're giving them? Who cares about the dose? That's up to them, as long as they're better tomorrow than they are today. Let them define success. But that message can't stop at the pharmacy. As frontline healthcare professionals that we are, we're open late, we're open on weekends. And with that accessibility comes responsibility. So we have the responsibility to educate our community around safer supply. So with our role, and taking our treatment hat off, we have to then educate our communities. There's a large conversation already about housing, and we're starting to see some of the negative effects of safer supply among rooming houses and leaseholders and landlords saying, I don't want those clients in my my buildings because they're just using drugs. I don't care where it comes from. And they have to realize that we have to do a better job educating in and around what safer supply is so that it is fully adopted in our communities better. And I think, as a community pharmacist, it could be one of the roles where we do really, really well. We're coming off a fantastic high. We just got off a power play, as a hockey terminology, from COVID-19. We're open, we were accessible, we gave vaccines, we have masks. Now let's take that goodwill that we've earned in our communities and turn it towards safer supply.
Yeah. Jodi and then Laura.
I think, Mark, you made a lot of really excellent points. And my, I guess, question I always ask is, how do we help other pharmacists who don't have that perspective come along that continuum, right? How do we show them? And I think we need to find ways to show pharmacists that maybe aren't directly involved or are reluctant, what are the benefits we're seeing, right? How do we address those fears? So I think, there needs to be a way where pharmacists, have access to some communication to give some real, sort of like particular examples, whether that includes, patients, specific stories or prescribers, feedback. That pharmacists are very hesitant because it does really shift our whole way of thinking. And I agree with you, once you really look at it for what it is, it makes so much sense. When I realized years ago that, not every patient's goal was abstinence, and that shouldn't necessarily be, where I'm trying to get them to, then I started asking what's better. What are you doing? Like you said, what are you doing better? Oh, I've reduced my use from this many points to this many points. Well, we should be celebrating that. That's huge, right? So I think there needs to be those conversations with pharmacists about what are those other measures of success. And then that helps pharmacists adopt the idea that we're still doing something good. We're doing something positive that's benefiting our patient.
Thank you. Laura, you had your hand up.
Yeah, I'm so excited to be part of this because it's nice to hear like-minded people saying the same things that I always teach and talk about. But Mark's point about what is success, I always tell my students, change your definition of a win, right? What is your definition of a win? And if you go into all of these things thinking that you're going to achieve abstinence and they're going to be housed and having a job and all of these things in a 6-month period of time, you're going to feel like a failure pretty much all the time as a clinician. Change your definition of a win and create a relationship. I think we have a responsibility to have a relationship with our patients, to really make them feel human and feel valued. Because you have to remember that by the time they come to see you as a community pharmacist, they have been stigmatized at every turn. So we really have that job, and that in and of itself, building back some of the trust in a healthcare practitioner can be a huge win in and of itself. And in that same vein, we also are responsible for advocating for these patients who often are voiceless or have voices suppressed because we have such a medicalized model and really think that only people with letters after their names really have the right to speak to these issues, when really it's people who use drugs that are the experts on these things. So I really think we need to advocate for their voices to be heard. And I think I completely agree with what everybody else is saying. Change your definition of a win. If they show up every day for their dose and have a smile on their face, that's a huge win in my mind. So yeah.
Absolutely. Ash, go ahead.
I agree with everyone, but maybe the most important thing I want to insist on is the role of the community pharmacist, because he's the go-to person. So we need to remove that stigma from the pharmacist, because the patient will be convinced if the pharmacist is giving him the medication. Most importantly, and I have seen it, the families. Some of the younger clients that are like on addiction, like they would come to the pharmacist and ask and inquire. And I have seen a case where the client has actually passed away because his parents tried to remove the safe supply from them. So if we remove that stigma from the pharmacist itself, like the pharmacists have to believe in it, they would actually save lives.
Absolutely. Danny, you had something to say?
Yeah, I think certainly one of the advantage of being a pharmacist is that we have that touch point every day with the client. Right? So we see them every day. The nurse practitioner, the prescriber, even the outreach worker, a lot of times don't see them on a daily basis. Right? You might see them, the outreach worker may see them 5 days a week, usually weekends and nights, you don't see them. But we typically, if they're really compliant, they'll see us every day, either at a brick and mortar location or we go see them. So there's the opportunity for us to work directly with them. So great, we give them medication, but use our time with them well, how to do that. That's some of the stuff that I really try to understand where the challenges are from, what the circle of friends are from, the connections are, understand the lingo, so then I can be part of it and sort of be waiting around when that conversation comes, when they start asking questions, gee, I'm really having sick enough of this, what do I do next? And then make sure you connect them and so on and so forth, right? In terms of community pharmacy, I think there's a lot of stigma out there, but also some of the practice out there probably not set up. It's hard for someone to come in and then when you already have some kind of idea what the people might be like, or they're troublemaker or whatever, or you go to pharmacy, they will have separate lines for people that taking either OST or OAT, what do you call it, and regular patients. So it is very difficult. I think if more pharmacists want to do that, they should not think about. I think most of us in the panel are probably higher volume in terms of doing safer supply patients. Maybe they can do 1 or 2, and that's all you do, and kind of learn from there and get the build a relationship with them, right? And I think that would go a longer way to sort of maybe scaling up later on. At least that you get some understanding. When we first started doing this, we have about, including me, 6 pharmacists in our practice. We actually would have harm reduction sessions, learning about different things, learning about how they, for example, crush hydromorphone, inject it, and so on and so forth. So you actually understand what they do, try to understand the lingo, and so on and so forth, right? So, so if anyone want to do that, they really maybe go to a pharmacy that do safer supply, like one of us here, and then kind of walk you through and see what we do, what the challenges is you see, and then maybe that might make it easier for them to come on board and having fewer patients, not more, just so that you can get more handle on it and get a variety of things going on.
Yeah, the stigma piece is absolutely huge and inescapable, as someone's saying in the chat. Lynn, you had your hand up.
Well, I guess this might follow along with stigma as well. As I really question whether we need to see them every day. I think that daily pickup is not a punishment exactly, but it's definitely something which ties someone to having to be, at a certain place at a certain time within a time frame. And I guess I'm wondering if we actually need to be doing daily pickups for everyone. I know it's sort of a trend. Certainly I see it here with most of the prescriptions, even for prescribed safe supply, but in theory, prescribed safe supply should be more open-ended, and in fact, OAT should probably be more open-ended to retain people in treatment as well, but that's a whole other topic. So I guess that's my question. Why are we seeing them every day? For some, it might be possible, but as a standard of practice, do we need to? That's just a question.
That's a good point. I imagine for some people, it's kind of nice in one way to be able to have that connection, but yeah, your point is well taken. Definitely a hindrance in some ways. I kind of lost track of who was next. So jump in if you think you were the next person with your hand up. I think it might have been Laura.
I think it was me.
I think it was you too. Yeah, go ahead.
So first of all, I completely agree with what Lynn just said. I think we have to put a lot more autonomy in the hands of people who use substances and realize that they know their bodies better than anybody else does, and give them a little bit more of that autonomy and trust. And in doing so, I think we would earn back a lot of other trust. The other thing I wanted to say to the original question, I think it was the original question, what is the role and responsibilities of the pharmacist in all of this? I also think we have a responsibility to our profession to take, we've got this group of people here that are very pro supply, safe supply and all these things. We need to spread that message out in whatever way that we can. So whether that be if we are taking students on rotation and we are educating them that way, if we teach at various colleges across the country, if we can lobby government agencies using our voice and our education to do that work, is I think also a professional responsibility and a role that we can really play in expanding safe supply and decriminalization.
Thank you. Mark, were you next?
Hi. I guess I'm going to pose a sub question to pharmacists' roles and responsibility. I would love to hear the voices of these wonderful people asking, do you think that pharmacists should be approved to be a safer supply pharmacist, have specialized training in, like Danny said, harm reduction, in proper stigma training, so that when people go there, they have a certain expectation of how they should be treated? Or are we limiting then professionals who want to be involved? I don't know the right answer. I'm just kind of curious what you guys think as our responsibility of pharmacists.
I don't know if I can jump in there. I was thinking along the same lines. In BC, we have mandatory OAT training for pharmacies and pharmacists that want to be involved with providing OAT. Although I think it's significantly lacking because it focuses much less on patient care than on sort of punitive measures for the pharmacies. I feel like, again, that is a mechanism, if it's done right, that can educate pharmacists and help them to have all of that sort of history and skills necessary to to support patients on safer supply. So I've wondered that as well, because I think we are doing patients a disservice when we're sending them places where they're only being further stigmatized. And I think that it can be a real opportunity for people to connect with healthcare in multiple ways, and it can connect them with further care if they so choose with OAT, or connect them with primary care. We've seen in my patient population a lot more engagement with all facets of healthcare and outreach once they're on safer supply. So I think that's definitely a valuable thing to discuss. Another point that I just wanted to make was with respect to dispensing daily. I mean, I see the value because of the fear and the risk that can happen. But one of the things I've wondered about as well is in sort of collaborating more with like supportive housing and things like that. I work directly with the shelters and supportive housing. And there are times when, if I was permitted to, patient is at work, I could leave it with the staff, they could communicate with me and things like that. We're very limited now in our ability to do that. BC isn't even fully in line with the Health Canada Section 56 exemptions on that in terms of leaving doses with other people. But I think there is a huge opportunity there where we could support patients in sort of expanding their life and giving them a bit more ability and flexibility if we were able to engage more with those partners.
Thank you.
Can I jump on as well?
Yeah, please do.
I think the daily interaction is actually important, depending on how you have that daily interaction with your patient. Believe it or not, most of our patients want me to see them every day, because when we go see them every day, it's not. I think we all hung up on about delivery, about giving them medication, making sure they swallow and watching it. That's really a small piece. That's a piece to get you in. Really, what happened when you get in there, then you can kind of work with them, right? You can chat with them. A lot of time may not be anything, but just about anything. Just get to know them better. Often when I rolled out in my day-to-day, I would have ensure my car, I have water, I have cigarettes, I have harm reduction supply. You name it, I have almost everything. So when I see them every morning, especially the one in the emergency shelter, they might not have any food or stuff. Often we'll dose them with some insure. And that's like, they look forward to that just because they nothing to eat. And it's hard. So we try to build that rapport and use that to see that see every day to also kind of give you a sense how they're doing. Because different time of the month have different challenges. End of the month, they might get the money coming out, and then they might get robbed, or they all of a sudden disappear for a few days because they need a break from being quote unquote good, whatever term you use and use. And then we had to catch when they come back, or by middle of the month, or they ran out of money. It's a different situation. So there's multiple things. And a lot of times they actually talk to me anyways, about the kids or other stuff, that other trauma. And you try to just be the person there to have that conversation. Often there's not really people around And just being a familiar face on a daily basis, just say that, hey, I'm here for you. It actually means a lot. So I'm not sure that though, by giving somebody more supply is always helpful. Maybe a population would be, others may not, because often it can be that though they have a bad day and use more, now had less for the next day, and then now they might have to use some more stuff, so on and so forth, right? So I think there's probably some people probably do well with a daily, and other people may be good to be not every daily. But I think those are probably individual cases we should look into rather than just across the board and say, hey, do we need daily or not?
Yeah, and Danny, you've talked before about being able to see your patients every day and develop that relationship with them, and how that can be good for both you and for the clients. I wonder too, like if we can talk just a little bit about some of the challenges. So for example, for those pharmacies who may not be open or available 7 days a week, what happens then for the clients who are expected to come for their daily dispense? What have you guys felt or done as workarounds for that? Go ahead, Danny. Is your hand up, or is that from before?
No, so we pretty well try to accommodate 7 days a week. Rarely we give someone a carry, but if they do need a carry, especially they're stable, they've been seeing you every day and there's no issue, then that's fine. Some people are not stable at all. They're still using on the side while we're dosing them. So they might still use quite a bit, and not a little bit, then you gotta be careful. But often if we're not there, we do give them a carry, but this is really rare for us because we're usually around. But I think some places do carry. And again, some people are afraid about diversion. We're giving carries. But then the question about diversion though is that, is it so bad if they got clean supply out there being diverted versus more more toxic supply out there? So, but that we not one of the challenges for us. And one time what I did though, when we really cannot be around and use a third party, we actually do a FaceTime with the meds. So when you don't have a lot of people to do, let's say a couple of people, for whatever reason you cannot see them, we can actually FaceTime them. So what we do too though is, because most people we see have no ID. You have no idea you got right person, not right person. So once we make that identification the first time, we have pictures of everyone, and that's how I identify them. So we know who to dose. If let's say I'm not going, somebody else is going, we can do. That's how we do that, right? So.
Lynn, your hand was up as well. Go ahead.
I guess this is something that I struggle with, and it's kind of back to the daily dispense thing. And I understand totally why it's that we do it. But in a way, in my mind, it's separate and apart from prescribed safer supply or from safer supply, because we're medicalizing it in a way. I think it's one thing to have access points to care. It's one thing to have a good report with patients. It's one thing to have check-ins. But when we make the decision that that person has to come in every day versus them choosing to come in every day, that's a whole separate thing. But when we make the decision that they have to come in every day because we don't trust that they won't divert it, or that they won't take it and we watch them take it, or whatever, in my mind, that walks away from safer supply. Because really what we're just trying to do is to get a safer drug in their hands. The rest of it is the next step. And it seems to me that by putting those requirements, and they are requirements in a lot of situations, people must come in every day, or they have to only take their drug in the clinic, which takes all his staff, and then they have to be this and they have to be that. That medicalizes it even further in my head and creates barriers that we don't necessarily need. I think we're probably just not comfortable yet with the idea of providing, fairly potent, sought after therapies, drugs, but I think it shows that we don't trust people, that we, need to keep an eye on them, and that kind of thing. And if they choose to come in, great. But if we script it for them, I'm not sure. I'm not sure that we're doing them good or not. You know, I think we have to think about that a little bit. And I'm not saying that it's totally wrong to have daily dispense. I just think we should look at it in a way that isn't the way that we do it, but is it the right thing for this person in discussion with that person?
It's a really strong point, and I think it also brings into consideration the role of the prescriber here, which we can come back to. But Jodi, you had your hand up for a bit.
Yeah, and I think that there's a lot of good points there. One thing that I consider, like we like I said, we do outreach and we go to patients as well, especially at the shelter. And for them, I also look at the risk to the patient potentially of having more medication on them. So in those type of environments, it's quite risky if they were to have multiple days worth of medication just in the environment that they're living in. So in that case, again, we go to them and we try and alleviate that extra burden on them. But there certainly are limitations with that. And I think that, again, it is going to come down to prescriber comfort level too. And I mean, looking at each individual situation is important. We have one prescriber who's quite flexible with carries, especially since COVID, and making sure all those, is there a safety plan, is there family that can help, or those type of things. They live out of town, is it really prohibitive for them to get to the pharmacy? So we're starting to see some people looking at that, which I think is really good on an individual basis, and hopefully that continues.
Thank you, Laura. Go ahead.
Just to the question about how to sort of deal with a pharmacy that's not open 7 days a week. I just wanted to highlight some cool technology that's available and becoming available in certain places. There's a thing called MySafe. We've been trying to get one in Nova Scotia for a while. That's basically an ATM, and it's prescribed. You have a prescription, but you go up and you sort of enter your health card number and your ID, and your prescription comes out as safe supply. Pharmacists still have a role; they check it, but that there's some cool technology coming out. Whether or not it's perfect by any means, I'm sure lots of my fellow panel members have opinions about it. But there's some cool technology that's even being looked at to have this as a workaround to increase access to safe supply.
Thank you. Danny, go ahead.
Yeah, I just maybe I wasn't speaking well, so my piece is very different. We actually currently have no one coming in my pharmacy for safer supply. It's all completely outreach, and so and just like Jodi says, if you give them more supply, sometimes that's so much you can trust them, not trust them. It doesn't really matter. You want to take more or less. They have to deal with some of the consequences, but often they might get wrong. So when I actually go down to safe supply, that's a shelter setting. Certainly you had witnessed Canadian, and then to dialogue it, I always make them put in front pocket in their pants. Jacket usually get lost. Somewhere else get lost. They can lose it quickly. And then so what happened then when they lost, they don't get that supply back anymore, or you had to go through a prescriber to try to get that. And it's another barrier they face, right? So it's and in a shelter setting too, though, they already got lots of drugs going on the inside there besides just your safe supply. So putting more stuff around it may not be helpful. So maybe when someone living by themselves, they are fairly stable, that's great, right? They don't need to come see you. So we try to have that meet you where you at model. So we come and see you. You don't come to see us. So that kind of takes some of that piece out and really try building relationship, right? See where they at. A lot of times they have mobility issue or accessing things. So you become kind of the touch points to, hey, I need to get on so-and-so, or I need to go see a prescriber, or they can't get phone call back, or they have no phone. So we kind of help them all that kind of social work piece. So having that daily contact is actually important. It's not about the medication, about building relationship and help them with some of those barriers.
Thank you. Mark?
Laura, fantastic. I think what we're thinking about when we talk about all this daily, not daily, and the debate, it boils down to, again, us trying to define parameters for patients, right? So let's let them define it based on successes. And I understand, like, listen, I was involved in the development of safer supply with Health Canada. We had to land somewhere, right? With some sort of guideline around what we're going to do. And we guess threw a dart at the wall. Maybe But now we have to adapt through education and experience, which is great what we're doing, right? It's fantastic. Laura mentioned something called MySafe. MySafe is actually a program where they want to control kind of what's being dispensed and some of the data. The company who makes the machine is Dispenssion. So we've tried to implement that. So I would, rather than having a MySpace program, how about we have a locker system where people can access things at different hours that meets the needs of them so they can work, such as in our 1 to 3 overdoses in Canada in the construction sector or whatnot, right? So maybe a new technology, using technology, interfacing with pharmacy to be able to provide that outreach that doesn't really require human contact. Great for some. I would alarm with those machines right now. We've even tried to implement one. I say we, I mean the lovely people at Inner City Health here in Ottawa, one of our partners at Safer Supply, and putting one actually inside of a safe consumption service. So that there's, we have the service, we have the safe consumption area, we have it secured, just a locker to pick up, to not to require prescriptions and whatnot. And it's still an interface nightmare, right? So it's working on it, it's getting there. But that's where the innovation technology needs to go. But again, I think as pharmacists, we need to kind of say, we don't choose here, let the patient choose. And I think that's got to be the primary focus.
So much. Yeah, there's so much I think that we can continue to talk about for every single point that's been brought up. Just in the interest of time, I wonder if we could just quickly shift gears a little bit, just to talk about tips and things that behind the scenes type things that you think might be useful for other pharmacists to know who are either considering getting into safer supply or who have found themselves in a situation where that's one of the expectations that they're providing safer supply. So anything that you think might be useful for pharmacists to know about how to be as effective as possible. Do you have any thoughts on that at all that you'd like to share? Jodi, go ahead.
I think, again, just looking at providing to pharmacists who are just getting involved in this, sort of what those parameters, kind of like we talked earlier about what success looks like. And in the BC, the update to our opioid use disorder treatment here, there's a sheet that goes through like what are the clinical and the psychosocial benefits you could be looking for, and it will help pharmacists then frame sort of what that looks like. And I find that's helpful to review because it gives you that confidence and reassurance that what you're doing is benefiting. And I think that that's really important for people to have that sort of frame of reference. So if you're understanding truly what your aim or what the patient's goals are, and we talked a bit about that. Other tips too, I think, for pharmacists to understand that we can maybe share, I can share, is that, a lot of people worry, oh, they're just going to want more all the time, or they're going to always be saying it's lost. We don't see that. Like, we haven't seen that. So I think it's positive for people to hear that and have that fear kind of allayed, that that's not necessarily what you're going to experience, and sort of to start with an open mind.
Thank you. Ash, go ahead.
I think for community pharmacists, the most important tip is connection and communication with our clients, actually listening to them. Again, some of these clients are being stigmatized by lots of people, including other pharmacists. So when they find someone that are listening to them, listen to their needs, what they need, as long as, again, very, very politely, like we do with any other client, explain, like, we can't, for example, give a replacement without authorization. Very nicely and politely, they communicate and understand that we are on their side. The moment they understand that we're on their side, there's a connection, they can trust us, they can follow us when there's something wrong, we got their back. We help them, and that's what makes them improve as well.
Absolutely. Laura, go ahead.
Ash said it so perfectly, but I just wanted to say that before you sort of get into this kind of work, if you've never really done much harm reduction work before, my tip is to make a really searching, deep dive into your own soul for any stigma that you may be holding on to, because internalized stigma within health professionals is what perpetuates stigma outward to the rest of us, to the rest of the community, and our patients and our the people who use drugs are up against it at every turn. So really make a searching inventory of any internalized stigma that you have, and try to quell it. And I found the best way to get rid of internalized stigma is do what Ash said and create a really great connection and develop a relationship with these patients, bond over, you know, a crossword puzzle, or did they read Lord of the Rings, and you know what's their favorite Disney movie and why. You know, all of the, if you can create those bonds that are outside of just the medical, I'm your pharmacist, you're my patient, any stigma that you have internalized tends to disappear, because you realize this is a real human being that really likes the same Disney movies that I do.
Yeah, absolutely. Just a quick message that we're going to do the poll now. So we'll keep the conversation going though, but in the background, it's in the chat, you'll find, you can go ahead and do the poll. Jodi, go ahead, you had something to say.
I really think that that is important, connecting with your patient on a different level, and that's where the whole kind of get out from behind the counter and that separation of pharmacist and patient, you know, it doesn't need to be there. It doesn't really serve us looking at this sort of, you know, uneven playing field basically. So I do find the same thing when you actually meet people where they're at and you talk about things that aren't specifically related to their medications, that's where that trust builds. And I would also encourage people that are unsure of safe supply or just getting into this in their communities, try to connect with the clinics that are offering this service, the mental health substance use teams, your outreach teams. Connect with them, go to their events, go and learn more. And then you kind of immerse yourself in that and you have a better understanding. And also when you have those relationships, trusting with whether it's the prescribers or the other service providers, you feel more confident as well in what you're doing. And I think that sort of collaboration and that also relationship is really important.
Mm-hmm. Yeah, absolutely. I think that we will, there's so much to talk about, obviously, and we can continue this for, I'm sure, hours. I could talk to each of you about every single point that's been brought up. I think that we'll move on to some questions, if that's okay. And there was a question that was posed. Historically, increased availability of narcotics has led to increased rates of addiction. What would you say to detractors that believe that safer supply is trading a lower risk of death for the current generation with increased rates of addiction in the future generations? Yeah, I get this question a lot and don't have a good answer for them right now. Laura, go ahead.
We were all very quick to click the hand raise on that one, because it's such a classic thing to hear, and it's not based on any fact at all. Human beings have been using substances since human beings have been on Earth, and there has always been access to substances since human beings have been on Earth. So increasing access of safe supply does not increase addiction rates. In fact, there are countries that have decriminalized drugs and introduced safe supply where addiction rates have plummeted, because it is a trauma situation. People are trying to fill their lives up with substances to make themselves feel something. And, you know, if we can actually fill their cup up with other things, substance use, nobody wants to be in active substance use or chooses to live such a stigmatized life. If we can remove that stigma, then substance use rates drop. So that statement is not based in fact at all. It's based in fear, and it's based in lack of education. So that's what I would say to people.
Thank you. Lynn, you had something to say to that?
Just a few things. Well, first off, in BC, we have about 7 people dying a day from the tainted street supply. So that's in itself is something that probably overrides any risk of potential harm outcome. In our prescribed safer supply program in BC, because it's really moving outside of what a lot of people are comfortable with and sort of outside of evidence with the use of all kinds of fentanyl products and now fentanyl capsules for smoking, we are and have developed a fulsome evaluation and monitoring program that is the contract has just been signed, and the group will be beginning their evaluation and monitoring, because we are looking at that. We know that when we used hydromorphone tablets for harm reduction with risk mitigation of the dual emergencies during the sort of the COVID and opioid issue, that there were reports of diversion of the tablets. And we heard reports of there's more sale, the price has gone down. There are more hydromorphone tablets available for sale on schoolyards. We had some reports back from some physicians at one of the universities saying they had this sense that they were seeing more hydromorphone use in some of their student patients, et cetera, et cetera. A lot of it anecdotal. But the fact of the matter is, we know that in some cases in hydromorphone, with hydromorphone, because it wasn't the right drug and it wasn't solving the problem that we were trying to solve, that there probably was diversion and there probably were people who were accessing it. However, we have no indication that hydromorphone was part of any of the overdose deaths or anything like that. So, it's a very tough situation, but we have an emergency right now. People are dying unexpectedly. And so you kind of have to look at the risk benefit, and we've got the evaluation in place, and we will make adjustments as things go on. And the other thing I'll say is that if we'd had safe supply early on, maybe not safe supply because at the time we didn't know if it had to be safe, we probably wouldn't have such high fentanyl addiction right now, because one of the reasons we do is that people kept using the street supply and ending up with massive fentanyl addictions. I mean, right now, it's sort of as just an example, for people who are using fentanyl patches for safe supply, you're seeing people who are using 10 of the 100 microgram patches every 2 to 3 days. So that's their dose. It's so much higher. Reports back on some of the initial smokable fentanyl capsule models is they're seeing like 24,000 micrograms a day. That's a lot of fentanyl. This is what's keeping people, or where they're ending up based on titration up. So we wouldn't have this kind of a huge addiction problem with drugs if we'd actually had a safer supply early on. So I don't know the answer to the question. It's something that we all worry about. We're monitoring for it in our province anyway, but I don't think that the facts bear out that concern to the same degree as the issues that we're dealing with safe supply.
Okay, Mark, go ahead.
I think, for naysayers and especially in our own profession, you just got to look at, okay, we had methadone and Suboxone when we had a heroin OxyContin problem. Now we have a fentanyl, carfentanil problem. What are we doing to bridge the gap? It's not going to work, right? So, and what has been working, what is happening is not working. Deaths are up to a Canadian every 36 or 37 minutes right now. If you look at that staggering data, I mean, I fully disclose, I'm that moron who developed the fentanyl patch return program. How stupid was that in a way, right? I mean, back then we thinking that, supplying and controlling access and talking about fentanyl was the only way to really do this. And I mean, that was my intent. I'd give out fentanyl now, probably exact opposite guy. I mean, it's because we're not stopping the problem. We had a big push on deprescribing of opioids over the last decade, thanks Purdue. Let's face it, it was based on lawsuits, it was based out of fear. And by reducing prescribing, I think is one of the contributing factors to where we are now. It pushed people to the street and newer alternatives. So we got to take a step back and say, okay, how much of the responsibility is on healthcare? Guess what? It is ours, right? So we are the gatekeepers as pharmacists of opioids. So we have to accept responsibility for what we've done. Take off your silly white coat. We don't make anything and do something different. That's what I'm trying to tell you guys is, what pharmacists need to be is, we have to have some of that kind of we have to bear some of the responsibility for where we are. And by refusing to refill somebody who is early, or rather than having a really cool conversation with them about why they are early in a non-stigmatic way, this is the kind of change we have to be. So we got to say to those naysayers that putting people in jail doesn't work. Drug access to jail seems to be better than outside, I was told. Let's put them in treatment instead. What does that look like, right? Is treatment safer supply first, then treatment? I don't know. But we got to start thinking different because what we're doing now isn't working. That's the simple answer.
Yeah. Just in the interest of, thank you, Mark. In the interest of time to move on to get a few more of these questions. There's a question about what is the impact or support of the colleges of pharmacy on how progressive a pharmacist can be with safer supply? Are college regulations a barrier? And related to this, another question. All of you are doing impressive. The question is about justifying your brevity with the respective colleges. This person did a course on deprescribing and tried to implement it, but the college had not been very pleased. So anything, if that makes sense, I can repeat the question if you want. Lynn, go ahead.
I don't want to always jump in, but I've spent a goodly amount of time over the last few years working with our college in BC, trying to figure out how to maneuver past all the what appear to be barriers, legislation, regulation, practice policies, etc. And the one thing that I learned about the college that I mean, I think I probably already knew it, but like we always give, it seems like they have a lot of power, which they do have over us, but they derive their power as such, or their regulations, their practice policies that restrict us based on what the standard of practice is. They don't determine the standard of practice. So when in BC, for instance, if the BC Center on Substance Use posts guidance on how something should, like a program, fentanyl patch program, fentanyl, Fentora, oat, whatever it might be, the college then looks at that and writes the practice policies. Our job, I think, is to make sure that those guidance documents that they use as their gold standard to put their practice policies in place aren't so rigid that it creates rigidity in how pharmacists have to practice. And I know that that's problematic and we're all worried about our college, but to be honest, the way around it is not to, browbeat the college and beat them up, because they can only do so much. If it actually says this is how pharmacists should practice, or this is how a program is to be run, and it says it on it's maybe a standard of practice that you follow in certain specialties, or it could be something that's on the BCCSU website, that's where they're going to derive their practice policies from. So we have a way to influence our colleges by their by making sure that we have input into the way those guidance documents are written. At least in BC, that's the case. So for instance, we're rewriting some of the OAT policies so that they will actually put in place somewhat less restricted practice policies under certain circumstances. So they're definitely there. They're not as bad as it seems, but the way around it isn't to try and get them to change what is a standard, but to change the standard so that the practice policies work around it. At least that's how I found the most success.
Mm-hmm. That makes sense. Laura, go ahead.
I feel like it's always me, I'm sorry. I feel, so a couple of things just came to mind when we ask about colleges. First of all, the college, if your college is, like our college here in Nova Scotia, I sit on a harm reduction working group that was working on updating our harm reduction policy and standards of practice. And we really had a lot of discussion in those meetings around stigma, because you'll see a prescription written for Dilaudid, hundreds of tablets for somebody for chronic pain, and nobody will bat an eye. But if we write a daily dispense for somebody as a safe supply, there's going to be all this pushback and hoops. So I think there's a lot of still internalized and systemic stigma that needs to be dealt with. But like Lynn said, I think we do have the ability to advocate at our college and change those practices by asking, like, can we not talk about the stigma, that the big pink elephant that's in the room of the stigma that is inherent in this policy? Can we bring in people who use substances to these meetings, pay them for their expertise, and listen to what they need, and then act on that? Those are the things that I really think we need to be doing as pharmacists.
Thank you. There's another question. Do you have thoughts on how safer supply can be distributed in communities without pharmacies? So for rural residents, for example. Lynn, go ahead.
Sorry, you guys, I don't want to hog the conversation, but we've given a lot of thought to this, and we're working a lot on rural and remote communities through FNHA, which First Nations Health Authority in BC. And it's tricky, but one of the things that really has helped is the Section 56 exemption that talks about transfer of controlled substances to clinics. So, I mean, there has to be a place to send it, or has to be a place to house it once it gets to the community. But so, for instance, a lot of the First Nations communities, they have community health centers or nurses clinics. And so there are all kinds of ways that we can try and get some access to at least, stat or early medications in those communities. It's always tricky for the really, really remote ones. The rural ones are easier to work around, but the ones that are really remote, where they have to take boats and planes and a variety of ways, or drive many miles and for many or kilometers or hours to get there, it is tricky. But that transport of controlled substances to a clinic on site or some sort of medical unit on site has been helpful in some of our access. The access still crappy, but it's still, and then the use of virtual care for prescribing and that kind of thing, I think is important. But anyway, it's not ideal, that's for sure. But there are means that we're looking at for sure.
Yeah, it's something for now. Jodi, go ahead.
I was just going to echo what Lynn said. I've had conversations with local First Nations here as well. We're looking at, and for me as a pharmacist, my problem is I don't know what or who to liaise with to make sure we do that all properly. So like, Lynn, I would appreciate hearing more from you in the future, but I've been talking with some of the nurses at the primary care or the nursing stations at in the local areas here, and that's something they are very keenly interested in doing. So I'd like to find ways to do that and make sure that we're doing it, in compliance with all of the regulations and the standards. But there is definitely an interest and definitely a demand for some of these communities to have quicker access to their medications. Even where we are, I mean, it's 15 kilometers away, but that's prohibitive for people coming in to get their medication. So I'd like to find out more ways too that we can formalize that type of relationship with the nursing facilities and have them, dispense on our behalf. And then what does the communication look like? How do we document that? How are we processing that? So I really hope that there's more to come on that, because I think we have a big opportunity.
Thank you. There's two questions related to client needs. The first is, in terms of advocating for people who use drugs, voices to be heard regarding their needs and experiences of stigma, what do you think are some of the specific ways that pharmacists can do this? Have you done this with some of your clients? Laura, go ahead.
So that's a really great question, because it's something that is very near and dear to my heart. So I have done this in a few different ways. So running Bloom programs, usually we have training sessions to get pharmacists trained. And back in the times before COVID, when we could do those in person, I always had somebody, a person with lived or living experience, come and speak about their experiences and what they need from a pharmacist. I do the same thing in my substance use disorder classes at DAL here. I get folks from SUNAR usually to come and talk about their experiences with pharmacy. I think when you're having any meetings like at a college level or anything like that, if you're invited to sit on any committees, and it's about people who use substances or about substance use disorders, advocate for somebody with lived experience to be there and to be paid for their time to be there for their expertise. I think at every turn, wherever you're talking about substance use disorders, we should all adopt the phrase "nothing about us without us," so nothing about them without them, and bring them in at every turn is sort of how I operate. And there's drug user advocacy groups across the country. If you don't know of one in your local area, you can reach out to Kapud, who is aware of pretty much all of the groups across the country, and they are consummate professionals, so excellent, thrilled to be involved, and really the best voices to have at the table. So if you're not aware, definitely reach out to Kapud.
Thank you. And the next question related to client needs. How can the issue of safer supply in the communities be addressed? Lack of Black pharmacists and culturally aware pharmacists. I don't know if I got that question correct.
I'm not sure I understand
I don't know if
exactly.
I don't know if that question came through. Okay, sorry. Let me read it again. Where did it go? How can the issue of safer supply in the Afro-Caribbean Black communities be addressed? Lack of Black pharmacists and culturally aware pharmacists. I don't know if there's any thought on that. Okay. I think it's hard sometimes with yeah, perhaps if the pharmacist, you know, or if the client doesn't necessarily identify with the pharmacist that way, culturally speaking, that can definitely present a barrier. And I feel like that's probably in general an issue within pharmacy that hopefully is improving. Another question is, it would seem that most retail pharmacists are already extremely under-resourced. They often don't have adequate time for routine tasks. How do we ensure that resources, including the time needed to work with complex patients, such as safer supply clients, is available? Go ahead, Mark.
That's again along the whole approval thing. If you don't want to be in it, don't do it. You know, or do we advocate for better funding models from provincial government authorities for this, right? So it's a combination of both. It goes for better coverage of large dose pharmaceuticals and non-pharmaceuticals, but also in and around the scope of, you know, deeming pharmacists as professionals and being then paid for their time speaking, not just dispensing. We got to move away from just the dispensing function and more into a collaborative professional function, right? And what that looks like, I am not a policymaker, certainly, but I can love to sit on those boards in and around what that looks like. And in safer supply, we know the time required as clients potentially charge their phones and want to have a conversation in a warm place with you anyway. That humanity piece is a piece that can't go away for this to be successful. So that requires time and maybe, you know, remuneration. I think that will then open up the tasks, the staffing, the ability then for you to add on facilities, provide unique facilities, provide better facilities as small community operators, right? Because I am a business owner and operator, certainly, and I understand the challenges faced with the labor required to do safer supply effectively.
Thank you. Jodi, go ahead.
I think that Mark made excellent points there. And I think that, you know, I think the points need to be made, you know, provincially and federally that these interventions are cost savings for the healthcare system in so many other ways. And our investment in the time that we devote at that level can really circumvent a lot of other needs for patients, being whether it's, you know, hospitalizations, ER visits, whether it's infectious disease, wound care, that type of thing. We can have a lot more impact, and the cost savings. Unfortunately, pharmacy and pharmaceuticals gets a lot of buzz in terms of the value, that the high dollar values and things like that. But it really looks at, we really need, I think, to focus that messaging provincially on what are the impacts and interventions we're having at that level, and the value there needs to be recognized. I know in BC we actually do have a witness fee for our methadone prescriptions in addition to your dispensing fee, but we don't have that for Cadian or Suboxone or other things which are actually more labor intensive. Same with safe supply, right? I mean, whether or not we need a witness fee, we're not witnessing, but I'm just saying that fee associated with the methadone prescriptions was beneficial, and it was encouraging people to get involved with treatment, but it hasn't kept up with the needs of our practices, basically, or the staffing that's required for some of these things that are very complex, and where we do need to sort of implement technology in some way to streamline our processes and ensure, you know, accuracy and safety. So I think that the funding certainly needs to be looked at in order to get other pharmacies more willing to participate. And I think if we want pharmacists to actively, you know, get on board and be, you know, a contributing member to this patient population, it does need to have, there needs to be an investment there.
Yeah, thank you. Those are really interesting points. Lynn, did you want to say something?
Yeah, I just wanted to add quickly that, in fact, that's actually what there's a group within the Ministry of Health in BC actually looking at that, trying to figure out how to do a different funding model that's not tied to dispensing, because we all know there's all kinds of issues around dispensing, but it also puts pharmacists in a perceived conflict of interest in a sense, because everything that they do, if we want to expand, say, to pharmacist prescribing or anything like that, if they get paid to dispense as a part, anyway, it's a long story, but you can see that there are all kinds of issues that we look at. But the fact is, we don't reimburse pharmacists. I mean, I'm one, I know exactly for all the things that are done that you can't charge for. I also know that, you know, from an internal perspective, there are difficulties, because we need to be able to be accountable for what we do and to show that we actually achieve what we're supposed to do to get paid for whatever it is that they're paying us for, which then puts in all these forms that you have to fill out and signatures you have to get, or you may not be able to. So there's, it's trying to find that balance and trying to figure out what's fair, how to reimburse. Do you just pay portion of a salary of a pharmacist and just not tie it to anything, but have expectations of X number of patients? How do you do it? And I think part of it is not just intent, it's process. How do you do it? And so if any of you have any brilliant ideas, feel free to send me some.
Maybe Laura does.
Yeah, so the Bloom program actually sort of does that. It's a little plug here for the Bloom program. So it's a provincially funded program through Nova Scotia Health that I run. And basically, pharmacists are paid $75 per month in a capitation model to enroll patients with mental health and or substance use diagnoses, to work with them over the course of 6 months on goal-oriented tasks. So it could be, you know, Mary Smith is feeling, you know, has depression and wants to get back to gardening, or it could be, you know, so and so needs access to safe supply, and we're going to work together to get that. And they're paid monthly for their clinical activities involved in this goal-oriented longitudinal care program. So it was created as a partnership between Dalhousie and Nova Scotia Health Authority. And I can share papers with folks about how it sort of works and how it got funded through Nova Scotia government. But there are kind of unique things. This is unique in Canada and maybe North America. But there are other similar types of programs that harness that for other non-mental health indications. So we can look at those types of funding models to be like, hey, let's pay pharmacists for the clinical care of these patients rather than just filling a prescription. And yeah, the Bloom program is one small example of that.
Thank you, Laura. And one more comment before we wrap up. Danny?
Yeah, I agree with Jodi and with Mark. I think the way the funding model currently, it doesn't work. I think most of the time, though, we do think of pharmacies as just a specialized distribution site. We are doing well for giving stuff out, but we do a lot more other stuff. And most time when people talk, they don't talk about professional fees, they talk about dispensing fees. And it's kind of punitive. The more you do, you don't get paid more. It's matters back. It's actually detrimental as you're running a business from business perspective. The more time you spend, the harder you are, because more people backed up, but you don't get paid any more money. So how do you balance that? So a lot of pharmacies actually only really operate on giving stuff out because they really, not that they cannot do more, but they have no time to do more. So we do have to change our funding model to think about how we're doing that. I think that though, when we're talking about, there should be some kind of standard to do safer supply or addiction mental health pharmacies and so on and so forth, and find a different funding model, like when you talk about with not capitation, but paying a fee for doing mental health work or something like that. That's kind of way to go. It's almost like in some way health physicians are being paid too, right, based on what they do and what code and stuff like that. So besides just dispensing.
Thank you. So cognizant of the time, it is just about 1:30, and I know there were lots of questions that we didn't get to, but I'm told that Rebecca and team will follow up with all the questions that were unanswered. Yeah, so with that, I'll thank everybody for their time.
And then I will jump in as well. I want to thank you all, our roundtable folks, for being here today, and our amazing moderator, Kelly. Thank you so much. It's really important to have your faces here, to have your thoughts shared with this group. And I hope we can do another one of these, because there's just so much more to talk about. I just want to let everybody know once again that if anyone's interested in joining the community of practice, you can go to our website, which is, here's our website. That's where you can join so that you can participate in members events, get information from us. We also have a lot of resources, including a prescriber consultation line. Yeah, we're always looking to build our community and make sure that we're tapping into the existing expertise that's out there, and also providing support and sharing information to help support new providers, new programs, so that they can do this effectively, comfortably, safely, all of those things confidently. Lynn.
I just wanted to say that I got a text during our conversation today from a friend and colleague who is a nurse practitioner prescriber, and she just wanted me to let people know how valued community pharmacists were in her world and how much she appreciated the work that we did and having community pharmacists available for her patients. Just saying.
That's so great you shared that. Thanks, Lynn. With that, I'll say goodbye to all of our attendees today. Thank you for joining us. We will share a survey and ask that you do fill that out. That helps us continue to be able to offer these events and helps us improve and make sure that we're providing the kinds of events that interest you. And again, big thanks to our roundtable panelists. And big thanks to all the community pharmacists and all the other people involved in all the different aspects of pharmacy out there. Really appreciate it. Our panelists, if you'd like to, would like to stay on for a few more minutes to debrief, that's great. I also recognize that a lot of you have to dash off back to providing the services that you provide. So thank you again for your time. I know it's a busy time of day for all of you.